All right, I'm back. This is Jessica Taddeo. I'm going to go ahead and move on with my examination of my patient. I had him go ahead and lay down for me, and so what we're going to do is we're going to do a cardiovascular examination. All right, and I'll go ahead and wash my hands before we start, and I apologize if my hands are a little cold. So I'm taking a look at his chest as he's lying flat. We're going to start with inspection as always. I'm looking at his jugular veins. I don't notice any jugular venous distension. I'm checking to see if there's any pulsations. Oh yeah, I can see his carotids pulsating.
Hope so.
And I'm inspecting the chest wall for any heaves or lifts. I'm looking over the aorta to see if I can see any pulsations over the aorta, which I do not. And then I'm just going to go ahead and palpate. I'm just going to feel your chest here, sir. So I'm just kind of palpating the chest for any tenderness, feeling for any heaves or lifts or anything. And I'm going to go ahead and look for the point of maximum impulse here and see if I can feel that. When I practice on my son, he's super skinny, and I can feel like his heart in like all of his chest. And my husband, it's a teeny more difficult, but I can feel the PMI right here. Perfect. So inspection, palpation. They don't usually percuss the heart, so we'll go ahead and kind of skip over that. I'm going to listen to your heart next and just kind of breathe normally. Don't take any big deep breaths. Just breathe normally. Just relax. Take a nap. I'll just be over here auscultating your chest. So we're going to listen over the aortic area first. The aortic area is going to be in the left second interspace. So I'm just going to kind of feeling the ribs to make sure I put my stethoscope in the right spot here. And I need to listen with the bell and the diaphragm. If I had a diaphragm, it would be on the other side of my stethoscope here. I mean, if I had a bell. Okay. The next area is the pulmonic area. So I'm listening for the presence of S1 and S2. I'm noting if there's any extra heart sounds, S3 or S4. I'm listening for any murmurs or gallops or pericardial friction rubs. So the next is the pulmonic area, and that is in the second left interspace. So we listen to the aortic in the right and basically just move across the chest on the left. And it's kind of like on the sternal border. So we're going to listen. I'm going to go ahead and listen with the diaphragm and the bell. All right, S1 and S2. The next is the tricuspid area, which is going to be along the lower left sternal border. And the bell. listen over the apex of the heart or the mitral area. With the diaphragm and with the bell. I'm going to have you turn kind of over to your left side.
Do you
Like,
want me facing that way?
yeah, I want you laying on your left side. So kind of on your side. Perfect. So I'm going to listen, have him lie on his left side and listen again over the mitral area. And this is the best place where you could hear any murmurs to kind of check for mitral stenosis. Okay, and I don't hear any murmurs or anything like that. I'm gonna have you go ahead and sit up for me. Just gonna do
Which way?
kind of just up to your feet, like over here, and kind of sitting up. Okay, and what I'm gonna have you do is kind of lean. Ooh, whoopsie.
My fault.
Technical difficulties. Oh, don't pause it.
Oh, I didn't pause it.
Okay, all right, we're back.
Again.
I was trying to get this camera. So what I'm going to have you do is kind of lean forward, kind of like that. And again, I'm listening over the apex of the heart, and this is the best place to listen for aortic regurgitation. So what I'm going to have you do is take a big deep breath, and then exhale and kind of hold your breath out just for a few seconds for me. Okay, if you have to breathe, that's fine. But just try not just to breathe everything out and just leave it out for just a minute while I listen. Okay.
Okay.
All right, big breath in and out. Okay, good. So if I did hear a murmur, you need to note the timing. Is it between S1 and S2? Is it after S2 and before S1? The location, like where you hear, anatomically you hear it the loudest. And the intensity, you would grade the murmur. Grade 1 would be like the quietest murmur, and grade 6 would be like the loudest. And like you can supposedly, I don't think I've ever actually heard anybody with a grade 6 murmur, but supposedly you can feel a thrill in the area where it's heard the loudest when you have a grade 6 murmur. So that is pretty much it for just the heart examination. Part of the cardiovascular examination is we're going to go ahead and check the pulses. If you could move my camera back a little bit so I can view my patient. So I'm going to palpate all of his pulses, and I could have done this before when I was palpating, but I kind of just wanted to focus on the heart and then move to all the arteries. So I'm going to palpate the temporal artery. Okay, I can feel those bilaterally. I'm going to palpate the carotid arteries always one at a time. Don't palpate them both at the same time unless you want your patient to pass out. Okay, I'm just going to feel over here. So I'm feeling for any like lifts in the carotid upstroke. Good. I'm going to check the brachial artery here on the arm. Oh, I'm feeling this one. Good. And on the other arm. All right, the brachial arteries are 2+ bilaterally. I'm gonna go ahead and see if we can hold the camera so I can see. So I'm gonna feel the popliteal artery behind the knee, and kind of want to hook in and okay, good. And behind the other knee. Good. Posterior tibial. And dorsalis pedal pulses. His pedal pulses and his posterior pulses are a little bit diminished compared to like the brachial. He does have some poor circulation. He's diabetic, but they are palpable. Actually, this one's pretty strong. Maybe I didn't feel it on the other side as good. I take that back. They're not diminished at all. Let me feel this one. Okay, good. Yeah, the pedal pulses are 2+ bilaterally. I need to also go ahead and listen to your aorta. I think I'm doing this kind of out of order because I had to have my patient lay back down again, but I could have done that while he was already laying down, but we'll just go ahead and have you reposition here for me. So before, when I was inspecting, you know, I looked over the aorta for any pulsations. I did notice, I could see his aorta pulsating a little bit earlier. I actually had never noticed that before on him. I don't feel any masses or anything like that. I'm going to listen over the aorta. I'm going to listen for bruits. I'm going to listen over the aorta, the iliac and renal arteries, and also the femoral arteries. It would be easier to auscultate the femoral arteries, not through the pants, but we're not going to take the pants off for the sake of the video. And I did not palpate the femoral arteries before. I'm going to go ahead and see if I can feel this femoral artery. Again, it's easier not through the jeans, but so yeah, femoral arteries good bilaterally. And then the carotids, I need to auscultate over the carotids, and again, for any bruits. With my diaphragm and my bell. So a bruit would be like indicative of some turbulent blood flow if there's like carotid artery stenosis or something like that. So I don't hear any bruits or anything like that. So for the cardiovascular examination, My patient, his heart rate is regular. There's no murmurs or gallops or pericardial friction rubs noted. S1 and S2 are present. He has 2+ pulses bilaterally, temporal, carotid, radial, brachial, femoral, popliteal, posterior tibial, and dorsalis pedal pulses all were palpable and 2+ bilaterally. And there was no tenderness over the chest wall to palpation, no appreciated masses or heaves or lifts over the chest. So that is pretty much going to be the extent of the cardiovascular examination. And again, in practice, it may be easier, kind of do the anterior lungs and the chest, the cardiovascular part, kind of all at the same time, because you're looking at that part of the chest. But for the sake of the video, I've gone ahead and just separated those parts of the exam to just kind of practice on those certain body areas. So that will be it for now. I do want this video to be a little bit longer, so I'm going to go ahead and just practice some stuff. Sir, if you could go ahead and sit up for me. I'm going to just run through a quick, you want to put your shirt on? Would you feel more comfortable?
Whatever you need.
Okay, whatever you want to do. I'm just going to run through just a quick HEENT examination for the next few minutes. Just want to make each of my videos about 20 minutes. So I'm going to look at his head, and the head is normally shaped. The facial features are symmetrical. There's no obvious lesions, masses, lumps, or bumps. So the head is normal cephalic, atraumatic. That's pretty much with the head. The eyes, I'm going to go ahead and look at the external eyes. Eyelids, eyebrows, eyelashes all appear normal. I'm going to take a look at the lacrimal ducts. There's no abnormality. I'm going to look at the condition of the eyes. They appear moist. There's no excessive tearing, and they don't appear to be excessively dry or anything like that. And I'm going to look at his pupils and just kind of take a look. Pupils are about 4 millimeters. I'm going to check for their reactivity to light. If I could dim the lights, I would. And bring my little remote over here. So just go ahead and look ahead of me. So I'm just going to shine a quick light in your eye. And again on the other side. Good. So the pupils are equal, round, and reactive to light, and when one constricts the other, so accommodation. And I'm going to test for extraocular movements. So I'm going to have you look at my pen, and we're going to move your eyes this way, move your eyes this way, move your eyes up, move your eyes down, move your eyes this way. And so all 6 cardinal visual fields, gaze fields, extraocular movements are intact. I'm going to check the corneal reflex. Kind of just, wait, open your eyes. You should blink when I put a little cotton over there. Let's check visual acuity. I'm going to have you hold my little sign, and with both eyes, you can read to me the smallest line that you can.
4, 2, 6, 7, 3, 9.
All right, good. So that is both eyes. I'm going to go ahead and cover your left eye. Read to me with your right eye, the smallest line that you can.
4, 2, 6, 7, 3, 9.
All right, and I'm going to go ahead and cover your right eye.
9, 3, 7, 8, 2, 6.
Okay. So the left eye a little fuzzy. So 20/20 OU, both eyes. 20/20 OD in the right eye, and 20/25 OS in the left eye. I'm gonna go ahead and take a look at the ears. When I look at the ears, I'm looking at the external ears. I'm looking for any lesions, any obvious drainage from the ear canal, any external redness or foreign bodies. And also looking at the skin of the ears. Sometimes behind the ears, people forget to put a little sunscreen on their ears so they can get like a little, you know, like a skin lesion, a skin cancer on the ear. So always good to kind of check behind the ears because people can't generally see behind their own ears. So I'm gonna look inside the ear with my otoscope, and I'm gonna note the condition of the tympanic membrane. Should be intact, no signs of perforation. Normal color would be pearly gray, and you're looking for the cone of light and being able to visualize the internal structures, and just make sure there's no like obstruction with any foreign bodies or cerumen impacted or anything like that. And then also looking for if it's sort of bulging or should be kind of flat. If it's bulging TM, then it's kind of like some fluid behind the ear. So I'm just going to go ahead and kind of pull up and back and take a look inside your ear. And I can see the cone of light. I can see the malleus. His TM is gray. There's some redness, and he always has redness. He had terrible ears when he was a child and had so many ear surgeries and stuff, so I think there's scarring inside of his ears. So since I've been looking in his ears for a while now, this is normal for him. But like redness inside would kind of be indicative of infection, but there's no active infection in his ears. Again, on the other side, I'm looking at the external ear for any abnormalities, and I'm going to go ahead and look inside with my otoscope. I'm going to kind of pull up and back, gently insert my speculum, and looking, and I can see the cone of light. I do see the tympanic membrane. It is intact. I can see the malleus, and again some erythema around the outside of the TM, which I think is just scarring from all of his ear infections and perforations that he's had. He's had since we've been married, he's had multiple ear perforations, so pretty familiar with problems with the ear. You literally, like, green, purulent drainage just flows out of the ear. It's pretty gross. It's time to go. So I'm going to wrap up this video, and I got to go get the kids from school, and we'll finish with another 20 minutes or so in a little bit, and we'll kind of go through the respiratory and cardiovascular again. And thank you to my patient for being so amazing.